Good evening, and thanks for tuning in tonight. I'm Dr. Jonathan Sunkin, an orthopedic surgeon at Falmouth Hospital, and I specialize in hip and knee replacement surgery. This is Joint Explorations, a virtual education series focused on joint replacement. Tonight, I'll be talking about hip arthritis and hip replacement surgery. I did my undergraduate training at Tufts University, and after September 11th, I joined the Air Force. So I did my medical school at the Uniformed Services University, which is in Bethesda, Maryland, on the campus of Walter Reed Medical Center. I did my orthopedic residency in San Antonio, Texas, at the Department of Defense's only Level 1 Trauma Center. And I then served at Langley Air Force Base as an orthopedic surgeon, deploying to Afghanistan, Qatar, and Argentina. When I got out of the military, I did a fellowship at Brigham and Women's to specialize in hip and knee replacement. I see office hours at the Falmouth Orthopedic Center here at the Homeport Plaza on Gifford Street. And I also see patients at Stillman Outpatient Center in Sandwich. And you can call the number on the screen to make appointments at either location. So what is arthritis? Arthritis means inflammation or swelling of a joint. There are multiple different reasons that people can get arthritis. But osteoarthritis is the most common type, which is that wear and tear type pattern. Different inflammatory disorders like rheumatoid arthritis can also cause damage, as well as injuries such as fractures or infections. And the end result is a painful stiff joint. In the illustration on the left here of a knee, you can see the smooth cartilage that lines the end of the joint. And on the right, you can see some of those potholes in the cartilage and those bone spurs that can develop. And the x-rays show the same changes with that bone-on-bone change that we see annotated by the red arrows. Arthritis is very common. 23% of Americans have a diagnosis of arthritis, and that number seems to be increasing with time, possibly as we're living longer, staying active, but also as our population gets heavier. Arthritis can affect any joint. It can affect the shoulder, the knee, the hip, the spine, but arthritis in the legs tends to be more symptomatic because we walk on our legs, and knee arthritis is twice as common as hip arthritis. Tonight we're focusing on hip arthritis, and the hip joint is depicted here. It's a ball in a socket. The socket is the acetabulum, that's part of the pelvis. The ball is the femoral head, which is the top of the femur, which is the thigh bone. The cartilage lines both surfaces, and that's that gliding, cushioning surface that provides smooth joint motion. The labrum is a cartilage ring that goes around the hip socket, and that acts as a suction cup to further provide surface area for the joint. And the bursa is a fluid sac on the outer portion of the hip that can get inflamed and cause pain, and to be confused with arthritis. Here in the picture, you can see some of those same arthritic changes as depicted on a hip, where some of that inflammation and potholes in the cartilage, and also the progressive bone spurs that we see at the time of surgery, and also on the x-ray, where you can see we've lost the joint space between the ball and the socket, and you get that bone-on-bone change as cartilage thins out, becomes softer, and even develops cracks or delaminates from the bone in a very predictable manner. And again, it causes a painful, stiff joint. Hip arthritis affects about 8% of the population at a time, and people will often complain about groin pain or buttock pain. Usually this is worse with deep bending, like bending over to trim toenails or put on socks and shoes. People will also have pain with stairs or rising from a seated position. And symptoms can flare up and calm down, but tend to worsen with time. The initial treatment for hip arthritis is anti-inflammatory medications like Advil or naproxen. Celebrex is a prescription anti-inflammatory that we can provide that's designed to avoid heartburn that can be common with those other types of medicines. Tylenol is an excellent pain medication as well. Usually rest can be helpful for hip arthritis in avoiding some of those deep bending positions that aggravate it. Some patients will use a cane or a crutch as well. Physical therapy and cortisone injections work very well for knee arthritis, but don't tend to last quite as long in the treatment of hip arthritis. Patients will often ask me about stem cells or PRP injections, and it's exciting to think that someday we'll be able to regrow cartilage. But currently, the American Association of Hip and Knee Surgeons does not recommend any of these biologic modalities for the treatment of advanced arthritis. The outcomes are still somewhat unproven, and they're expensive as insurance doesn't cover these benefits. And so when we talk about surgery, we're really talking about hip replacement, which is also known as a total hip arthroplasty. And on the image on the left, you can see severe hip arthritis, that loss of joint space. And on the image on the right, you can see the hip replacement in place, appropriately positioned. These are what the actual implants look like. It's a titanium stem that goes down the middle of the femur. It's got a ceramic ball attached at the top, and there's a titanium socket with a plastic liner. And that plastic liner is probably the most advanced part of the whole hip replacement, and it's designed to wear out with time at approximately 0.01 millimeters per year. The surgery is performed first by removing the femoral head or ball, which allows us access to the hip socket or acetabulum. We use a reamer to remove the minimal amount of bone from the pelvis, and we're then able to implant that titanium cup with the plastic liner before we place the titanium stem down the middle of the bone. And that's what recreates that smooth, pain-free surface. There's a few different ways that we can access the hip. I prefer to do what's called a direct anterior approach, which allows for X-ray to be used throughout the surgery. The incision is on the front of the thigh, and we avoid cutting or splitting any muscle. Instead, we go in between the muscles. I will also use the posterior approach, which involves an incision on the buttock. And that is a very tried and true approach that we've used for a long time, and it can be helpful for primary hip replacement as well as revision hip replacement. Both of these approaches offer excellent outcomes, and a hip replacement is an excellent surgery. The anterior approach is performed with the patient laying on their back. Again, we go in between the muscles, pulling the tensor fascia lata laterally and leaving the sartorius in place. And this is what's known as an internervous plane, meaning that those muscles are supplied by different nerves. So there's minimal chance of disrupting any nerves or structures in between the two muscles. We also preserve the strong posterior hip capsule, which is important for hip stability. And again, because the patient is laying on their back, it's easy to use X-ray throughout the whole surgery to ensure that the implants are the correct size, they're in an optimal position, and that I can measure leg lengths in real time and ensure that I'm matching the patient's leg lengths up. After surgery, we instruct patients on safe positions to keep their hip, and I tell patients to avoid hip hyperextension and external rotation, which are positions that most people don't really do in an everyday manner. The posterior approach, the patient is laying on their side, and the incision is placed on the buttock. We split the gluteus maximus muscle. We reflect the short external rotator muscles, which are then repaired at the end of the surgery. And this allows us to have excellent visualization of the structures, and the incision can be made as small as large as needed. After surgery, we tell patients to avoid deep flexion or internally rotating the leg to kind of keep the hip in a safe position as it heals. With anterior approach surgery, I first identified the anterior superior iliac spine, bony bump, which is pretty easy to feel on the front of everybody's hip. The incision is then made just below and lateral to that. We then encounter the tensor fascia lata muscle, which again is pulled to the side, and we leave the sartorius alone, which has a sensory nerve on top of it. Once we're underneath that sartorius muscle, I then push the rectus femoris muscle medially, and then it gives you an excellent view of the hip socket, the acetabulum. I use a special operating table called the HANA table to help me visualize the femur at the time of surgery. And this table lets me individually manipulate the position of the leg to better gain access to the femur. And so the hip is extended and externally rotated in order to, again, adequately visualize the femur. It also makes it very easy to use X-ray throughout the procedure. The instruments I used are curved, which again allow me excellent access to the bony anatomy through a relatively small incision. The middle image demonstrates a femoral broach, which is a file that we use to prepare the femur. And on the right image, you can see an acetabular reamer, which we use to prepare the hip socket to accept the cup. We use X-ray throughout the surgery, and fluoroscopy is a X-ray movie camera that we use. And that helps us start with the image on the left and reproducibly end up with the well-functioning hip replacement like we see on the right. These are images during surgery, and you can see here that that acetabular reamer is in the hip socket, and I'm using that to remove the minimum amount of bone and also determine the appropriate size for the hip, the acetabular component, that cup. Here you can see that the cup has been placed within the pelvis with a screw for additive fixation, and I can make sure that that screw is an appropriate size. You can see that the femoral stem has not yet been placed. Here, the femoral stem, the broach, has been placed, and I can use a metal rod to measure the leg lengths by ensuring that it's flat along the bottom of the pelvis, and you can measure where this intersects the femur at the time of surgery in real time and make adjustments as needed. And this, again, is a picture during the surgery with the final implants in place in a position that's satisfactory. So some of the proposed benefits with direct anterior hip surgery are less pain and faster recovery potentially in the first 6 weeks. I also find it beneficial that I feel that the rules are easier to follow after surgery, and it potentially decreases the risk of the hip dislocating. I also find it extremely helpful to use X-ray during the surgery and ensure that the implants are the optimal size and the optimal position, and that my leg lengths are correct at the end of the case. After a typical hip replacement, patients are allowed to put full weight on their leg. We get you up and walking that same day right after surgery. It's always amazing that most patients have very little pain after surgery, even though it is a major operation. Physical therapy is focused specifically on walking and walking safely, as well as avoiding falls. And a nurse and a physical therapist will come to your house after surgery for the first few weeks to work with you. Same-day surgery versus one-night overnight stay has become the norm for joint replacement surgery, and most patients truly are happy and more comfortable at their own home. So hip replacement surgery has been termed the operation of the century, mostly due to its excellent long-term outcomes, the high patient satisfaction, and the long-term durability of these implants, with the hip replacement implants lasting over 30 years. And when you talk to your friends about hip replacement surgery, most patients truly just wish that they did it sooner. And so I want to thank you for your attention tonight. If you have any questions, I'm happy to answer those specifically. Or if you call the number on the screen, I'm happy to see you in the office. And so here are some questions from the audience. If someone needs both hips replaced, do you recommend having both done at the same time? It is possible to do both hip replacements at the same time, but I do not necessarily recommend it. Surgery is an injury of sorts, and even when the surgery goes perfectly, it really is up to you to heal. And I think the systemic injury with 2 surgeries, it does increase the risk of wound healing problems or infection. And so I typically prefer to do the surgery about 2 to 3 months apart. And I tell patients that once your new hip or knee is the good hip or knee, we could schedule that second surgery. But I really like to make sure that the first surgery goes well and that patients are happy with that outcome. Another patient asks, I had a hip replacement in 2017 due to a fracture of the acetabulum and a revision a year later due to a reaction to the titanium. It was replaced with ceramic and I am still experiencing stem pain. Can anything be done? So some patients, especially with fractures, can have a more complicated recovery than others. And I think that even though a hip replacement is the same surgery when done for arthritis as it is when patients have a fracture, the outcomes for hip replacement after a fracture are not quite as good as for arthritis. And I think to some degree, patients with hip arthritis are excited to have their hip replaced, and nobody is excited to have a hip fracture. And so patients can react to metal ions, although typically titanium is not reactive. And so if you are having pain, I would encourage you to come and be evaluated, to get new x-rays, and to make sure that you don't have an infection or that any of the components have loosened. Why is physical therapy less effective for hip pain compared to other joints? That's an excellent question. We know that physical therapy is very helpful for knee arthritis and strengthening the quad muscle in particular. And I think that the stronger you are going into therapy or into surgery, the stronger patients are coming out of surgery. And I still will offer physical therapy to patients with hip arthritis if they desire. I do think with the hip being a ball and socket in a relatively constrained joint, the more you move that hip around, the more it tends to flare up the pain. And so if patients do have increased pain with physical therapy, I tell them to stop the therapy or to limit those positions that are causing pain. And to some degree, that stiffness that people have with hip arthritis, you're kind of banging those bone spurs into each other and kind of causing more inflammation. So I do think physical therapy is okay for hip arthritis, but if patients find that it's making things worse, then I encourage them to stop. And cortisone injections are also an option for hip arthritis, but again, tend to not last quite as long as they do in the knee. Cortisone injections can be helpful in the hip for differentiating hip pain from back pain, which can sometimes be confusing. And if we do a cortisone shot into the hip and all of your pain goes away, even if it's only for a month, I think it is encouraging in terms of identifying the hip as what's causing the pain. How long is typical hip replacement surgery? A typical hip replacement can be done in approximately an hour to an hour and a half, start to finish. It really does take time to get into the room and to position the patient safely on the operating table. I also prefer to do a spinal anesthetic when that's an option, which also takes some time. And so it is about an hour and a half kind of start to finish that we're in the operating room. How do you decide which type of hip surgery you will use? What is the prep work? And so, with the hip replacement, again, it is the same surgery no matter how you do it. I prefer to do the anterior approach whenever I can, and I've done several hundred anterior hip surgeries, and I think the more that I've done, the more comfortable I am doing them now in patients that maybe before I would have done a posterior replacement on. I try to select an area where the skin is healthy because, again, it's very important that patients heal after surgery. If there is significant deformity to the hip, or if there is pre-existing hardware from an old fracture, then sometimes those are best performed posterior in order to gain access or remove that hardware that's in place. In terms of the prep work before surgery, the goal is to make sure that patients are medically optimized before surgery. I want the perioperative process to run very smoothly, and so we do talk to patients' primary care doctors. We talk to their cardiologists or pulmonologists if required, and we do everything we can to make sure that somebody is medically optimized to have a good outcome after surgery. What exercise restrictions are placed on the patient after surgery and recovery? Can they run? Should they avoid heavy weights? These are also excellent questions and are debated. Certainly, any joint replacement is a man-made thing that is designed to wear out with time. And so it stands to reason that perhaps, just like in a car, if you're doing donuts in the parking lot, you're not going to get 50,000 miles out of your tires, that perhaps increased high-impact activity could cause a joint replacement to wear out faster. My goal is to get you back to doing the activities that you enjoy doing. I mean, that's the reason that we're doing the surgery. And so I do let patients perform sporting activities within reason. And it's important to have good goals before surgery. I do think that lower impact activities probably are better for the longevity of the implant. But again, the surgery is to improve the quality of your life. And so I think there's a middle ground that we try to strive to obtain. I do let patients run short distances. If you want to be a marathon runner, I don't know that that's the best goal for you. Heavy weights are allowed within reason for hip and knee replacement. For shoulder replacement, which will be a topic of a future visit, heavy weights are restricted. What can someone do to keep their hips healthy and prevent hip replacement? This is also an excellent question, and we don't entirely understand why patients develop hip arthritis. There is a genetic component that is linked to arthritis. Certainly, again, injuries or diseases like rheumatoid arthritis can cause hip arthritis. We think that there is a spectrum of normal in the shape of people's hip, and conditions such as femoral acetabular impingement can lead to hip arthritis down the road. I will commonly see patients with arthritis of one hip and not the other. And so I don't know that there is anything that we know of right now other than possibly maintaining a healthy body weight that can prevent hip arthritis. Do you also perform revision surgery? I do perform revision hip replacement surgery. I will do that from a posterior or anterior approach, again, depending on the specifics of the current implants or the previous approach that was used and exactly why we're doing revision surgery. So I think one of the keys with any revision joint replacement is really identifying the reason for failure, and that gives us the biggest opportunity to fix a problem. And so some patients, like we heard from earlier, have a joint replacement and may have some pain, and it's very important to identify what is causing that pain. If it's a loose implant, if it's an improperly positioned implant, if there's an infection present, and that is the first thing that I consider is there infection around a joint replacement? For again, I will sometimes see patients with hip x-rays that look good after a hip replacement, but they go on to develop degenerative changes in the back, and that can be confused with a pain in the hip. Do you perform hip replacements in the hospital or a surgical center? I have done surgery in both locations in the past. Here at Falmouth, we do all our surgery at Falmouth Hospital, which I think has a lot of the advantages of both locations. Patients have the ability to stay overnight at the hospital if required. I have everything in the hospital that I need for every possible outcome. If there's a medical issue, if people have difficulty with anesthesia. But at the same time, Falmouth Hospital is a smaller facility. It's a very streamlined facility. And so patients are able to come into the hospital, have their surgery, meet with therapy that same day, and go home in a very smooth process with a very streamlined protocol. Is there a typical age range for hip replacement surgery? So if you're younger than 55, we consider you young to have a joint replacement. And in patients who are over 60, I tell them that that joint replacement should last forever. A younger patient potentially could wear out a joint replacement earlier and require a revision in the future. And so I do think surgery is always a last resort. I tell patients to delay if they can for as long as they can. But when patients tell me that they have more bad days than good days, if you can't walk 30 minutes because your joint is bothering you, then I do think you're missing out on activities. It's difficult to stay cardiovascularly fit. Patients have limited mobility and independence, and that I do recommend a joint replacement if nothing else has worked. And in younger patients, there really isn't another option other than a hip or knee replacement. And so there are conditions like avascular necrosis where patients do require hip replacement as young as in their 20s or 30s. And while it is young to have a joint replacement, I think it's also young to be dependent on a cane or a crutch. And I find that joint replacement in those patients leads to a very satisfactory outcome. Understanding that, again, in the future, they may need that surgery revised. I want to thank everybody for your questions tonight. If we're not able to answer your question today, please email them to us at outreach@capecodhealth.org, and we will follow up with you directly. If you would like to schedule a consultation, please fill out our form at capecodhealth.org/ortho or call our office at 508-457-4900. Thank you.